Thank you. Hi, I'm Michael Harrison. I'm the SLR accountant at Wrightington Wigan and Leigh. We've got Naomi and Shaun as well. And as mentioned, we won the HFMA Costing Award in December. So we'd like to take the opportunity today to share with you some of the things that we've done to make improvements and efficiencies at WWL and the reasons why we believe that we won the award. So you might be forgiven for thinking that this presentation will be full of lots of new and big and innovative ideas, but really what we've done is just use a combination of ideas we've seen at events like this in the past, learnt from others and tried to build on them with some of our own ideas and applied them at our trust. Primarily that's involved a big drive on engagement to give us some real results. So as a bit of a history and a background to our trust, we're an acute trust. We have 3 main sites, revenue of around about 300 million. In terms of activity, that's approximately 100,000 inpatients a year, about 500,000 outpatients and 90,000 A&E attendances. In terms of PLIX and SLR, we started our journey at the Trust in 2009, which was quite a long time before any of us joined. But it's now established at the Trust. It's been promoted internally, improved and refined, and it's firmly embedded. Our costing team is made up of me and Naomi as the dedicated costing accountants. We have support from our manager and good links with our business intelligence team. And we produce our PLIX data on a quarterly basis. We've always had clean reference cost audits and have received good feedback on our processes. The last full audit report we had said that we were an exemplar for clinical engagement. And more recently, we've been early implementer for the CTP. We've submitted twice now. And last year, we were a roadmap partner for the education and training return as well. So even though we were told our process for clinical engagement were great by the audit, we knew that in reality there was still plenty of room for improvement. We were sending our PLIX data out quarterly and going out to see clinicians and divisional teams wherever possible. And we were seeing similar themes crop up as feedback, such as they don't understand the data, it's too complicated, what are the overheads, they're not mine, why is it being apportioned to me, it doesn't match the income, I should be getting more for that procedure, and there's just too much and don't know where to start. Now, I'm sure none of these comes as a surprise to any of you here, and you're all coming up against these similar sort of barriers and feedback. But as we know, all it takes is for one thing to be out of place, and you can lose their interest. So because of those issues, our regular user stats had started to tail off, and we decided that we would have to do something to reinvigorate it. So we set about to address the issues and knew that the only way we could do this was through engagement. So one of the best things that we did was to secure executive buy-in. The Trust was running executive-led efficiency schemes, and one of them was focusing on maximising the contribution of specialties. So we met with our Chief Operating Officer, Mary Fleming, and showed her how SLR could be used for her strategic project and highlighted the opportunities available. Mary was already aware of SLR and the data it contains, as she chairs a monthly data quality committee, which we attend and present to, so she really supported the idea from the outset. We used a combination of SLR, reference cost and model hospital data to identify opportunities. We then went along to the project meeting and we presented the opportunities there to the divisional leads. And she set the operational teams the task of working with us to validate the data. This was probably the key thing that made the difference, as it put the onus on the divisional teams to help us get the data right. They could then have no complaints about the accuracy of the data, as they were given the chance to improve it with us in advance. Not only did this lead to some big numbers from the savings schemes themselves, but it really helped us to improve our data and gain some traction with people that we had previously found it difficult to engage with. And we've got a short video from Mary explaining how we were involved in that scheme.
The costing team were instrumental in the success of one of the cost improvement programmes that I led on called Maximising Contribution, which saved close to 500k last year. The project used a combination of service line reporting, reference costs and the model hospital to identify areas to make efficiencies. Divisional engagement was absolutely key, making sure that the data was valid and accurate before we made key strategic decisions.
So after we did that scheme, we also realised that we needed to train people how to use SLR. Because we've had SLR since 2009, as mentioned, there's been a lot of promotion in the past, and then that's died away because we've had different people coming and doing our roles and different people doing in the clinicians' jobs and in the ops team. So we realised that we needed to get back with that. So first of all, we started close to home with the finance department. As a department, we run regular lunch and learn sessions where a team hosts an informal training session on what the team does and how the rest of the team impact them and vice versa. It gave us a good chance to discuss things with people that we don't always directly deal with. This was well attended, and there were quite a few people that previously didn't really understand what we did that subsequently have got involved with us. We also tried to get involved with clinicians wherever possible, either through the monthly clinical cabinets, via management accounts, or directly with clinicians that we target due to having a gap in our cost allocations or specialties with losses or high RCIs. We take the opportunity through those channels to demonstrate how our dashboards work and try to discover if there are any areas we can work with the clinicians on. We also organised some pop-up sessions for clinical staff. We based ourselves in the hospital and people came to ask questions, and we demonstrated our data on an informal basis. This allowed brief chats that led to a couple of more in-depth meetings at a later date. We've also increased the profile of the costing team at the Trust through more regular board updates. So we send details of our reference cost process, we send our expected results and actual results, showing where focus is required. Again, we provide comparisons of our SLR, RCI and model hospital opportunities, and we try and triangulate the different sources to show areas with the most likely areas for opportunities to be saved. The exec-led efficiency scheme, previously mentioned, that reports to the board, so that raised our profile with the board. And some of the benefits of doing that made it easier when we were asking for funding for things like a new server. Another important thing that we do, we have a clinical costing lead for SLR, Raj Murali, who's an orthopaedic consultant, and we meet regularly with him. We've got a short video from Raj explaining how he assists us.
As clinical SLR lead, I meet regularly with the costing team, usually on a monthly basis, if not more frequently, to discuss how we can improve costing within the trust. I assist the team in linking them with clinicians with the required knowledge and skills to drive improvements to the way we collect data and present it to the end users. We have made changes to the SLR dashboard, which has increased interest and engagement and stimulated debate between clinicians to minimize clinical variation.
So as Raz said, he guides us on how to improve the processes from a clinical point of view, and then how we present our data to consultants. He also is really good at acting as a link between us and consultants. So having him champion the cause really helps with high-level buy-in, and it helps get our foot in the door to places. And I'll hand over to Naomi.
So we've got a continual improvement ethos within our team, and we're always looking to improve our processes, especially the engagement, as that's a key area we all struggle with. One of the things we've done is set up a new cost centre apportionment document. This is so we can easily show how the costs are going from the ledger to the patient. We've got the management accounts team involved in this, because they hold all the knowledge. We wanted them to validate all the cost centres in each of their divisions. It was a good two-way process because they understood how anything they do within the ledger, any changes, amendments, how it affects the costing ledger. So it's keeping costing at the forefront of their mind. And also we learned a lot. We understood more about what these cost centres were doing, what were driving the costs, which patients they were linking to. So it enabled us to change our apportionment tables where necessary. Our theatre allocations, we've changed these now more to reward the specialties for utilising theatre sessions. Before we did just equal split of costs down to session level and then whoever the patients were in there. And now it's more on the length of time. We can see how downtime affects the costings. We've also included the anaesthetists, the number of them and the grades that are in surgery at that time for waiting purposes. And then the same for the surgeons and nurses, it's all in that data. We hold quarterly sign-off meetings with the management accounts team. We tried to do this prior to a model build to preempt any changes, understand what's been going on in that division, getting that knowledge and feedback as well, what have the divisions been saying to them about costing. So again, that two-way process, and also keeping costing in the mind, always thinking about it. The prosthesis feed, we were just sat with a clinician one day and he said, my prosthesis costs on the patients are way too high, where'd you get your data from? So looking into it, the data that we got was from a system that wasn't being utilised anymore. Half the theatres were using it, half weren't. So he said, why don't you use the National Joint Register? We'd never heard of the National Joint Register. So looking into it, the data was just what we needed. It's all recorded there. We got reports back from the National Joint Register. We linked these with our patient data. And we've also got procurement involved to attach a price there. So now our prosthesis costs are so much more accurate, and the clinicians are happy as well, getting that buy-in. We have really good links to our business intelligence team. We've got support there when we need it. And we also use as many data feeds as possible from the data warehouse. Job plans were a big hiccup for us, really. We used to use the paper job plans and trying to chase these around the hospital. They'd be either non-existent or they might be sat on somebody's desk waiting to be signed off. By the time we got them, they might be out of date. So HR have now got a system called Allocate, which is really good. It's all on the system. We can go in, we can run the report when we need to. It's got all the up-to-date job plans on there that are signed off, and it means that those consultant costs are now more accurately put to their activities and then to the patients. Data quality meetings, we have these annually within the, not annually, monthly within the trust, and we sit on that board. It's a great chance to find out what issues are going on. There's a range of departments. There's us in finance, there's IT, there's coding, business intelligence, operational managers. So any issues with the data, we get to find out how it's affecting costing, and any issues that we find, we can take back there. For example, on our theatres, we were finding patients had just such high costs, and when you looked at it, they've been in theatre for 10 years. And you knew they hadn't. It was a typo. They put in 2009 instead of 2019. So it was getting the right people to help us change that. And now we've got a theatre app where there's a check column, and it flags up any patients who have been in theatre for longer than so many hours and that. So we can change that at source then, and that feeds back into our costing data. So I'm going to hand you over to Shaun now, who's going to tell us about how this has impacted us internally.
Yes, just to pick up on some of the things that they've, Naomi and Mike have already said, from a non-finance perspective, SLR and RCI can be really quite daunting, quite confusing. So it was really important that the approach that we had to this was really, really clear, and it was really, really structured so that the non-finance people like myself could understand it. But not also understand it, also have confidence in it and having trust in the data, because at the end of the day we were going to be making potentially some really big decisions based on what we were being presented with. So it was really important that the team and the costing team sat with us and were part of our project group. So they weren't just providing us with the data, they were actually sat with us throughout it. They were able to give us answers in real time rather than it being through email, which is sometimes it gets lost in translation. So it was really, really important that we trusted the data, and also that it was accurate as well. So as we've already touched on, the validation was really, really important, and that we were part of that validation. But it was also important to agree when we were going to draw the line in the sand, because I think you can go on infinitum, arguing the data and reviewing every single minute detail. So we agreed a point where we were going to use this data, and we were going to go away and we were going to start looking at it at service level to start identifying areas where we can make improvements and make efficiencies. So We had a project. As we've already touched on, we made quite considerable cost improvements from this, around just shy of 450,000 in terms of savings, and that was due to a number of things that we did. Some of it was cost reduction, some of it was joining services with other providers to make efficiencies. But the main thing for us was that at the end of the day, not just that it saved money, that it also improved services for patients as well, because it enabled us to reinvest. It enabled us to centralise services so that they were more, they provided more high quality to patients. So that was the main driver for us. But as soon as you can start to evidence that you're going to improve services for patients, it then becomes easy to get other people on board. It then becomes easier to bring your clinical teams into it, get them bought into it, and then you start to progress and make the changes then. So other things that we did were looking at efficiencies, particularly in outpatients, so the introduction of virtual clinics, which doesn't sound that groundbreaking, but it's about knowing where those virtual clinics should go, where you would get the most efficiency from them, which areas and which specialties patients would benefit the most. So that's a bit of a run through of how we got to where we got to, working with the team, bringing our clinical colleagues into it, and actually making some real improvements at the end of it.
Okay. So we've also had external impacts using our costing data. The data is used to work up the local tariffs with the CCG for the contracts, and also helping us defend the challenges that come back with us where they want to reduce block income. We've used the data to understand and agree some joint ventures. One was agreeing the baseline for our fertility fusion, having a joint venture with Liverpool Women's. I've got a short video where Phil Harris tells you more about this.
The costing team made it easy for both parties to understand and agree the finances for the fertility fusion joint venture with Liverpool Women's Hospital. The transparency of the data has helped us to create a great working partnership and ensure that my time can be spent on clinical duties, which has resulted in 473 pregnancies successfully since the project began.
There's also been other joint ventures with Salford for decontamination and Christie's for oncology, where we've used the data to agree contract values. We're always active in the national and regional costing groups, helping to share best practice and improve that consistency through the trusts. Other trusts have also come to see us, see how we've implemented SLR and how we're using it. It's great to share ideas that way. And we're really proud of the work we've done on the T&O tariff with NHSI, where it was found that the T&O complex revisions were big loss makers. So Martin Porter, our consultant, is going to tell you about that.
So the SLR team highlighted that our complex trauma and orthopaedic revision procedures were big loss makers. They worked with me and my team to ensure the data was accurate before informing and working with NHSI of the issue. This led to some great work between the Trust and NHSI, and with support from other specialist orthopaedic organisations, it will hopefully lead to an increase in tariff and support the GIRF getting it right first time agenda moving forwards.
So NHS and I have now looked into this issue, and this has led to an increase in the 1920 national tariff, and like Martin said, supporting the GIRF agenda. So our vision going forward, we're in the process of rebuilding our SLR model. As we mentioned, we've been producing PLICs for over 10 years. We've added lots of bits here and there, and it slowed the process down. We want to streamline it. We want to incorporate all the new rules for the CTP, or the National Cost Collection as it is known now, to help speed up that when we do that annual submission. It means the more we streamline it, the less we're sat behind our desk, and we can get out and engage and share that knowledge and experience within the trust. We want to set up a locality costing project with the council, the CCG and the mental health providers, and understanding the real cost of pathways. By focusing on frequent flyers and using the costing data, we want to work together to provide care in the most appropriate setting, increasing value and lowering costs. We've just taken on a big community contract in Wigan, which will hopefully provide that data as a starting point for this project. And finally, we need to keep the engagement going. It's a continual process, and we need to find new ways of working with clinicians, managers and teams, getting them interested and keeping them interested. The patient care environment's ever-changing. We need to keep up with that, keep up with the changes and incorporate that into costing. So we want to, with the help of Raj Murali, who you saw before, set up a costing club where clinicians and managers, any staff want to come and debate costing, share their knowledge and experience with us. I'll pass you back on to Mike.
And so that's our story, really. We feel that through all this engagement, we have embraced HFMA's theme of last year of Brighter Together. I really can't stress enough that it's engagement that is the key to making changes and having a positive impact upon your organisation. Even if it's just one person in a key role, preferably outside of finance, who really understands costing, understands why it's important and can champion the cause with you, it can go a very long way to raising your profile and opening doors for you. Getting people to trust and to have confidence in your data to make key decisions is what we should all be aiming for. Most of us probably spend too much time at our desks getting our model right. We know there are still areas to improve, and it's a continual, never-ending process, but even having all the numbers in the right place and the allocations perfect won't necessarily get you anywhere. You need to get out there and talk the data through with people. People don't trust data, they trust people. It is us and you that need to convince people that data is trustworthy. The more people you get on side, the easier it becomes, and you will really start to see the results. Nothing we have done is particularly groundbreaking. It is all about finding the right people, and to be honest, you might not get lucky on your first, second or third attempt, but there'll be people in your organisation somewhere that will be interested and will understand how beneficial it is to work with the costing team. You just have to persevere until you find them. Thanks.